Good afternoon. Today we're here with State Medical Director Dr. Brian Moore to discuss the changes in pediatric airway management for the April 2014 protocol update. Good afternoon, Dr. Moore. Thanks for joining us.
Thanks for having me, Leslie.
I guess our first question, we'll just jump right into it, is what brought about the changes for pediatric airways?
So the changes for pediatric airways has really been something that's a long time coming. Looking back at probably the most important study that was published in 2000 out of Los Angeles, Marianne Gaucher, that looked at really no benefit from pre-hospital pediatric intubation versus bag valve mask ventilation. Sometimes these things take a very long time before they get into textbooks, into mainstream, and a change of culture. Probably one of the other things that came about of why this is coming now, as I am a pediatric emergency physician. I am the only state medical director in the country that is a pediatric emergency physician. So this was hot on my agenda, looking at what we need to be doing for kids in the state of New Mexico and what's our best practices, what is going to save the most lives in kids.
I've had a lot of questions from the field of what if our paramedics go back to having a daily practice of those skills? Is it a matter of them losing the skill set? And if so, how do we continue that skill set? And would that allow us to keep pediatric intubation?
That's also a very good question. In Marianne's study, they actually went back and trained all the medics in LA and Orange County, every single paramedic, before they started this study, thousands and thousands of them. And all of them had had refresher training on pediatric intubation within the past 6 months before starting this study. So it wasn't that they hadn't been intubating or anything like that. These were all people who were newly trained in this again. One of the issues that we look at from the state is when we queried the MNSTARS, the NEMSTARS database, excuse me, we found that pediatric intubation was about 55 times a year for the whole state of New Mexico. And when we look at, there's over 1,600 licensed paramedics in the state of New Mexico, and you look at the averages, that means an average paramedic would intubate one child every 30 years, if you run the numbers, which actually is with what national data shows. And even if people say, well, we didn't put that into the database or whatever else, the national data would show that an average paramedic intubates a child once every 10 to 20 years. And there is a difference in doing it in real life versus getting the little mannequin head out and seeing if you can put the tube in. So I think practice is excellent, and I think we should be practicing other airway management skills, but I don't think that would, making everybody come in before the start of their shift once a month and showing that they can intubate the mannequin head would probably change that.
So proper airway management for pediatrics, what is the suggestion? What are the age limits and parameters for that?
So the scope change is up to 12 years of age, and all the way down to newborns, and we'll talk about that. I'm sure that question has come up, not just with you all, but many people have caught me in the hallway or in the ED, and what about this and what about that? Still, the gold standard is bag valve mask ventilation. We have not removed supraglottic airways from the scope of practice. New Mexico is actually very, very, very progressive on even allowing basics to do supraglottic airways. Well, first responders, but we removed that from this scope change because we saw nobody's used it. But in Marianne and other studies, they looked at bag valve mask ventilation versus endotracheal intubation, and especially in the kids that had respiratory arrest alone, the kids that got BVM actually had a better outcome, statistically significant, than the kids that got intubated. And we see that here at the Children's Hospital in the ER quite frequently as well. So my suggestion is learning how to do good bag valve mask ventilation, and sometimes it takes two people. We sometimes forget the very first thing at airway, which is suction. We need to use airway adjuncts like an oral or nasal airway. Supraglottic airways, there's no data out there yet. I think that they're fine to use. But even before the scope change went into place, well, it's not officially into rule yet, but even before then, I was already seeing a culture change. I saw many services, both local and surrounding services, just doing back valve mask ventilation and doing a great job with it. And even had a call the other day that the service was doing an excellent job of doing back valve mask ventilation, and the kid had a good heart rate and was pink and had, and I said, that's a great managed airway right there. That's perfect.
So then the question comes, what about those patient populations that cannot be managed with the super extraglottic airway, with upper airway swelling? How do you suggest us handling those situations?
So those are going to be extremely rare. If you have a obstructed airway with a foreign body, we did not remove direct visualization using a laryngoscope. So you still have the laryngoscope in your toolbox. You still have all the size blades. If you can't clear the airway via BLS, advanced life support can still take a look, and if it's appropriate with McGill's or whatever, to try to remove the airway at that point. Remove the foreign body from the airway at that point. People have asked about, burns and inhalation. I think especially for the Bernalillo County metro area, and you're so close to a facility, whether it's UNM at the trauma center or someplace else, that has some of the more advanced tools such as fiber active intubation and things of that sort. The time difference, it's really just getting them oxygenation and getting them here appropriately. I think it's extremely rare, and we shouldn't be teaching to the one case that somebody heard of in 20 years. I mean, we read it in the textbooks. We read about putting in, if they have soot around the singed nasal hairs and everything else to intubate. But really, around here, you're going to be to a facility really within 15, 20 minutes or maybe even 30 minutes, and you still have time on that airway.
So meconium aspiration in a newborn. Most of us use an ET tube attached with a meconium aspirator. Is that still applicable, or is that going to be changed as well?
So another question that's come up frequently, and I've actually talked to our neonatology colleagues, and the NRP program has really de-emphasized the suctioning of meconium, and it's really not indicated anymore if the baby's breathing and crying. I mean, when I was a peds resident, they had moderate or thick mech. Even if they were crying, you were supposed to suck it out and get every piece of meconium you could, and you would intubate and suck it out with a meconium aspirator, but those days are gone. Even in neonatology, they very rarely do that. So if it was being used for a suction device, then it's a piece of plastic like any other suction device. And if the baby's depressed and needs to be suctioned, then you suction the airway. But again, we really have de-emphasized, and the neonatal resuscitation program has very much de-emphasized doing meconium aspiration in any infant who's crying and has a good pulse. So not very often. You can use it to suck it out, but you can't leave the tube in. Then it's an intubation.
So have you seen a lot of change in how airways are handled in the in-hospital setting?
So the changes in pediatric intubation are not just from the field. We are very much de-emphasizing intubation, even in the emergency department or ICU. We're using lots of other non-invasive modes of ventilation. We have kids that we used to intubate lots of kids for bronchiolitis. Every winter we'd be intubating lots of kids. We're using high-flow nasal cannulas on those kids. Kids that maybe got too many benzos for their, not too many benzos, but they got a lot of benzos for their seizures, and they're a little bit hypoventilation. We would just pull the trigger and say, oh, let's just intubate them and let the ICU take care of it. Well, now, and they get to the ICU and 30 minutes later they're extubating them. I made one of my residents do back valve mask ventilation in the ED for 30 minutes because I knew the benzos would wear off and the child would be breathing and wouldn't have to intubate him. So, and it's not just here at our institution, this is a national trend, is that we're very much trying many other ways instead of intubating kids. So this isn't really something specific for the for the pre-hospital setting. We are doing it in the hospital, in the ICU, even in the operating room. A lot of the cases are being done by supraglottic airways where they used to be managed with endotracheal intubation. So it's not that we're just taking ET tubes out of the pre-hospital setting. I would say I personally intubate a lot less than I used to, especially when I was a trainee and a fellow and everything like that. And we're just finding much better success rate. Things like CPAP as well. We do a lot of CPAP and high flow nasal cannula.
Well, thank you. That's been very helpful. I greatly appreciate your time.
Thanks.